All right, engineers, so what we're going to do now is we're going to talk about the antibiotic management of pneumonia, again, because most of the pneumonias that we experience is going to be bacterial. We're also going to talk about some things that we should be utilizing in everyday practice to prevent pneumonia. We'll talk about some of the vaccines that they have out there. And then we'll just briefly mention some complications that can arise from pneumonia, some things that are really important that we should understand and can be very fatal. All right. I'm not going to lie to you guys. The antibiotic management of pneumonia is probably the hardest part out of all of this stuff that we're going to talk about. I'm going to do my absolute best to help it make sense for you guys, okay? So with antibiotic management, we have to go through this in the sense of the clinical settings that we talked about, okay? So here's how we're going to go through this. We're going to give this in different scenarios. So the first one we're going to start off with is we're going to start with community-acquired pneumonia. So let's start here with the first kind of situation. We're going to have someone come in and they're showing signs of community-acquired pneumonia, but they suspected signs of community-acquired pneumonia plus no comorbidities, and I'll explain what that means in a second, and no recent antibiotic therapy within the past 90 days. Okay, that's what we mean by ABX. No recent antibiotic therapy within the past 90 days. If some patient comes to you and they're showing these situations, community-acquired pneumonia, no other comorbidities, they're pretty healthy, and no recent antibiotic therapy within 90 days, you can give two options, okay? One is you can give what's called a macrolide. And if you guys haven't already, go watch our videos. We have videos on antibiotics. Macrolide is designed to be able to inhibit protein synthesis. One of the main macrolides that we would give in this type of situation is azithromycin. So you can give azithromycin. This has the ability to cover a lot of the different bacteria, particular to community-acquired pneumonia with no recent antibiotic therapy or comorbidities. If not, another thing that we could give is what's called doxycycline. And doxycycline is a type of tetracycline, and it is, again, a protein synthesis inhibitor. Okay? So these are certain types of antibiotics that we could give to someone if they have community-acquired pneumonia with no comorbidities and no recent antibiotic therapy. Okay? And again, it's either a macrolide, like azithromycin, or doxycycline. Let's go to the next situation. Okay? And again, this is someone coming in outpatient. So this, let's actually mark that up here. This is outpatient. So we're going to put this right here. Outpatient setting. Okay, so this is an outpatient setting. You're coming into your primary care provider and you're explaining all these things. They could give you a macrolide or doxycycline. Now, let's go to the next situation. Someone comes in, same thing, primary care provider, or they're coming in and you suspect community-acquired pneumonia, but they have some underlying comorbidity. Or they've had recent antibiotic therapy within the past 90 days. Now, what are some of these comorbidities that you should be looking into? Pulmonary diseases, for example, COPD, asthma, or liver disease. Chronic kidney disease is another one. Cancer, any type of immunosuppressive disease or immunosuppressant therapy. Another thing is heart failure or diabetes mellitus. These are some things that you want to take into consideration. So COPD, diabetes mellitus, kidney disease, heart failure, malignancy, immunosuppressive disease or immunosuppressive therapies, and another really big one is someone who has asplenia. So in other words, they don't have to have their spleen removed because it prevents them from being able to fight off certain types of encapsulated bacteria. Okay? So if someone comes in with this, what's your option? Well, you can switch it up. You don't have to, you can give these, again, we'll talk about what we can do with these, but we have to give it with something different. What we do is we can give what's called a respiratory fluoroquinolone. I'm going to put FQ here. Respiratory fluoroquinolone. There's a couple of these. You have moxifloxacin, you have your levofloxacin, and you have another one called gemifloxacin. One of the big ones that we'll give is levofloxacin. Okay, so what you could give here is you could give what's called levofloxacin. All right, so if we didn't give a respiratory fluoroquinolone, we could still do this. We could still give a macrolide. So for example, let's say that I give a macrolide or I give doxycycline. If I give this, one of these two, I have to give it with, I have three options, okay? One is I could do high dose amoxicillin or augmentin. And all augmentin is it's amoxicillin with a beta-lactamase inhibitor. It just gives some more coverage for resistant bacteria. Or you can give third generation cephalosporin. And this is usually and still in an outpatient setting. So this is still outpatient setting. Now, we come to the next situation. The next situation is someone comes in, they're really sick. And again, we're still with community-acquired pneumonia here. They come in, you suspect community-acquired pneumonia, but they are showing some really nasty declining symptoms. Okay, what do you do? Okay, what you could do is you could admit them into the hospital for observation. So if you have community-acquired pneumonia, they go based off what's called a CURB 65 score. So CURB 65 means C is for confusion, U is for uremia, which is high levels of the urea within the blood. R is for respiratory rate, if you have an increased respiratory rate. And B for blood pressure, if you have a low diastolic blood pressure or if you're greater than 65 years old. If you have 0 to 1 of those factors, you can just give them the antibiotics and send them home. If they have possibly maybe two of those signs, the CURB 65, then you're going to want to admit them into the hospital for observation. If they have greater than three or more, you admit them into the ICU, okay? So we'll talk about that in a second, the CURB 65, we'll write it down. But again, that's how you go based on it. CURB 65, confusion, uremia, respiratory rate, blood pressure, and greater than 65 years old. If they have 0 or 1, give them the antibiotics, send them home, outpatient. If they have 2, then you're going to want to admit them into the hospital. And if they have 3 or up, you admit them into the ICU, okay? So if they have community-acquired pneumonia, and let's say in this situation, plus a CURB 65 of 2, okay, well then we have to admit them into the hospital. So that is going to be admit into hospital. Now, if we do that, the antibiotic therapy changes up a little bit. So for example, you could still do a respiratory fluoroquinolone. But we change up if we're going to do another option. So another option is we could do, again, a macrolide, or we could do doxycycline. But if we do that, we give it with 2 other options. We can give it with ampicillin, or we can give it with what's called ceftriaxone. Now, ampicillin is a type of penicillin, right? It's a type of penicillin. And ceftriaxone is a 3rd-generation cephalosporin. So if we were to give macrolide or doxycycline, we would have to give it with ampicillin or ceftriaxone. All right, so that's that one. Community-acquired pneumonia for someone who's showing a CURB 65 score of 2, we admit them into the hospital. Now we go to the next one. The next one, let's say that we have a patient, they come in, they have community-acquired pneumonia, you suspect community-acquired pneumonia, a CURB 65 of 3 plus, so 3 or more. What do? You admit to the ICU, the intensive care unit, right? And that's going to change up, again, your regimen. Well, we could do similar things here. We can do, specifically, we can take ceftriaxone, so we could do ceftriaxone, or we could do another 3rd-generation cephalosporin, cefotaxime. And if we do it with ceftriaxone or cefotaxime, we have to combine it with 2 other options. So we can give ceftriaxone or cefotaxime, but if we do that, we have to give it with azithro or a fluoroquinolone. So azithromycin, which is a macrolide, or a fluoroquinolone, like Levo. Another option is we could do the same thing. We could do a macrolide or a fluoroquinolone, but we would do this with what's called ampicillin and sulbactam. It's also called unison, so they give it another name. We'll put that here. Ampicillin, that's again a penicillin antibiotic, right? Plus, we can give it with what's called sulbactam, and sulbactam is just a beta-lactamase inhibitor. Together, we call that unison, okay? This we can combine again with a macrolide or a fluoroquinolone. Now here's the next thing that you got to be aware of. If someone has a beta-lactam or a penicillin allergy, you have to be careful when you give them other antibiotics that are beta-lactam. So beta-lactams, I want you to remember penicillin, cephalosporins, carbapenems, and monobactams. If someone is allergic to penicillin, there is a chance that they can have a cross-reactivity with other beta-lactams. 3 to 10% chance of developing a reaction to cephalosporins, about a 1% chance of having a reaction to carbapenems, and then less than 1, very, very low chance of them developing a cross-reaction to monobactams. So if they have a penicillin allergy, the one that we like to give, the beta-lactam, is a monobactam called aztreonam. So I want you guys to remember that if the patient has a penicillin allergy, you want to give aztreonam. And aztreonam is a monobactam, which is a pretty broad spectrum antibiotic. It's a pretty good one. Okay, so penicillin allergy, you want to give something like aztreonam instead of giving ampicillin or instead of giving ceftriaxone. Okay? Now, this covers our community-acquired pneumonias. Okay, this is what we would give if we suspect this. Now, how long will we do this duration of therapy? Generally, the duration of therapy for community-acquired pneumonia is a minimum of at least 5 days. Okay, a minimum of at least 5 days. They also have to show signs of no fever. They have to be afebrile for at least 48 to 72 hours, and they have to have less than one symptom of clinical instability, okay, which goes based off that CURB 65 score. So again, when you're going to be doing the therapy, it's 5 days at least minimum, have to be afebrile for 48 to 72 hours, and have less than one symptom of clinical instability, okay? And the reason why you got to be careful is that you could treat them with antibiotics and you think that they're getting better, but actually you didn't cover the pathogen that is actually going to be the one causing a lot of damage. So your initial regimen might not work, and you might have to change up the antibiotic to cover the particular pathogen. That's why the antibiotic stuff is so hard and so important. Okay, so this is our community-acquired pneumonias. The next one we're going to go into is our hospital-acquired pneumonias. Okay, but before we do that, we have to talk about special considerations that you need to think about. Specifically, Pseudomonas. If you suspect that someone has pseudomonal infection, okay, so let's write this one down here. If you suspect, if Pseudomonas, then it's going to change up your antibiotic treatment a little bit. So what could we give? Okay, there's a couple options here. I want you to remember 3 of them. We could give, first one, they're all going to be pretty much the same. The only thing that's going to change is the other antibiotic. You could give Zosyn. You could give Cefepime. You could give Imipenem. Or you can give what's called Meropenem. But if you give any of these, you have to give it with something else. And this is where we're going to have the different types of options here, okay? Now, just to give you an idea, Zosyn, all it is it's actually tazobactam, which is a beta-lactamase inhibitor, and piperacillin, which is a type of penicillin. It's an anti-pseudomonal penicillin. Cefepime is a cephalosporin, particularly a 4th-generation cephalosporin. And then imipenem and meropenem are types of carbapenems. The carbapenems, these are really powerful broad-spectrum antibiotics, cover a lot of different types of infections. If you do this, you can give it with either a couple options here. First one, here we'll write this like this. You can do Zosyn, Cefepime, Imipenem, Meropenem. And if you do that, you can give it with here 3 options. One is you can give it first off with Levo or Cipro, okay? Second option is you can do an aminoglycoside. You're like, what the heck is that? Aminoglycosides are, again, protein synthesis inhibitors. One of the big ones is gentamicin. And you can give an aminoglycoside plus a macrolide, or the third option is you could do an aminoglycoside plus levo. Okay, so these are some of the options that you could do for someone that you suspect has a pseudomonal infection. The next thing is, if not only you believe Pseudomonas, but you think that there's a possibility of community-acquired Mrsa, then you do what's called vancomycin. Okay, vancomycin is a very powerful antibiotic. Or you can do linezolid. So, another thing that you should remember is if you suspect community-acquired Mrsa, you want to do vancomycin or linezolid. All right, guys, so I wanted to take some time, have Kristen come in, fix all this up. That's why it looks so pretty. It's important that we really understand antibiotics, because this is the hinge point for really being able to treat pneumonia properly. So it is important that we have a good understanding of this. So we've covered community-acquired pneumonia pretty well. What we're going to do is we're going to hop into the hospital-acquired pneumonia. Okay? Now, if you remember, hospital-acquired pneumonia is acquired whenever you've been admitted into the hospital for greater than 2 days, right? But here's the thing. When we talk about hospital-acquired pneumonia, there's two types, early onset and late onset. So what do I mean by that here? Let's write here, hospital-acquired pneumonia. We're going to put hospital-acquired pneumonia, HAP, okay? And this is hospital-acquired pneumonia that you have, we're going to say, early onset. So what does that mean, early onset? That specifically is saying that you have been in the hospital for greater than 2 days, but less than 5 days, okay? So you're greater than 2 days in the hospital, but less than 5 days in the hospital, or you have no multi-drug resistant pathogen. So that's important. Again, hospital-acquired pneumonia, early onset, it differs the way you treat. That's why it's important. If they've been in the hospital for greater than 2 days, but less than 5 days, or if they have no multi-drug resistant pathogen, in other words, it's not resistant, here's what you would generally do. You have 4 options, okay? First thing you could do, let's actually bring it all the way over here so we have plenty of room. First thing we could do is we could give either a 3rd generation cephalosporin. That's one option. A second option is we could give a respiratory fluoroquinolone. A third option is we could give what's called ertrapenem. Now here's the thing. Ertrapenem is a carbapenem, but it's one of the weaker carbapenems. Okay, but it's going to be pretty helpful for being able to treat early onset hospital-acquired pneumonia. So we can give ertrapenem. The fourth one that we can give is called Unicin. And Unicin is just ampicillin and sulbactam. Okay, so these are the 4 different things that we could give to someone who has hospital-acquired pneumonia, early onset, greater than 2 days in the hospital admission, but less than 5 days or no multi-drug resistant pathogen. Okay? Now, let's say that they're going to stay in the hospital a little bit longer than we want, right? So hospital-acquired pneumonia, late onset. There's a chance now that they have been there greater than 5 days, or they have developed a multi-drug resistant pathogen. Okay? This is important. Pathogens that become really, really resistant is your Pseudomonas, your Mrsa, your Enterobacteria, right? Your Actinobacteria. These are the really nasty ones that we have to be careful of. So how do we treat this one? So what we could do is, you're going to get the same thing for each one of them. So what you could do is you could give an aminoglycoside, like gentamicin, or you could give a fluoroquinolone. So what kind of fluoroquinolone? One of the good ones here is Levo, so Levofloxacin. If we give one of these, we have to give it with a couple different things. Okay, so what are some of our options? So one option is you could give it with Zosyn. Zosyn is piperacillin and tazobactam. Okay, it's a very powerful penicillin antibiotic. Second option is you could give this with another carbapenem, but it has to be a carbapenem that is not ertapenem. What are those? Imipenem, doripenem, meropenem. These are some really, really powerful ones, okay? So another option here for the third one is ceftazidime, or another option here is you could do cefepime. Okay, so you could do ceftazidime or cefepime. So if they have late onset, greater than 5 days in the hospital, or they've developed a multi-drug resistant pathogen, we give aminoglycoside like gentamicin or a respiratory fluoroquinolone like Levo, plus 3 options: Zosyn, a carbapenem, but not ertapenem, and a third could be either ceftazidime or cefepime. Okay? Now, here's the next thing, and the final thing, thank goodness, right? Is what if we again have Pseudomonas? We have to take into consideration some special circumstances. So, if there's Pseudomonas positive, we have to give some other options here. So what could we do? Well, we could give Zosyn again, but if we give Zosyn, we have to give Zosyn plus a couple different options. We could give Levo, we could give an aminoglycoside, we could give Aztreonam, which is a monobactam, or we could give meropenem. Okay, so that's one option. So we could give Zosyn, but if we give Zosyn, we have to give it with Levo or an aminoglycoside like gentamicin or Aztreonam or meropenem. Now, another option you could do if you want, if you suspect Pseudomonas, is you could do imipenem or meropenem, but you have to give that with Levo or Aztreonam. So that's another option that you could do here. We'll squeeze that one in here as well. So if I were to say this one, we could say meropenem or imipenem. But if we do these, you have to remember, we have to give these with either Levo or Aztreonam. Okay? And again, last thing, if you suspect Mrsa, don't forget, if you suspect Mrsa, give them vancomycin or linezolid. Okay? Really quickly, I want to mention some other things. So, we talked about Mrsa a lot. Mrsa, we already said that it's methicillin-resistant Staphylococcus aureus. It has beta-lactamases that break down a lot of different types of penicillin antibiotics, or beta-lactams. People who are more susceptible to Mrsa are going to be those who have been in the hospital recently, have been admitted, or they've had recent antibiotic therapy, or they have a history of colonization or Mrsa infections. And the last one is another important one, is if they have had some type of healthcare device invasively presented into their body. That all of those things increases the risk for Mrsa. Another thing that you want to take into consideration when you're doing all of this treatment is you're doing a lot of it IV. One of the things that you want to try to do is you want to try to switch from IV to PO therapy. But you want to do this whenever they're hemodynamically stable, they're showing signs of clinical improvement, they're able to tolerate oral medications or food. That's important as well, okay? So, the one last thing that I want to talk about, just so that we get this really down, I know I mentioned it before, but again, we have that Curb 65. Curb 65, I'm just going to have a little thing over here on it. I'm going to brighten it up here in this corner. C is for confusion. U for uremia, high levels of urea in the blood. R for increased respiratory rate, B for decreased diastolic blood pressure, and then 65 in patients greater than 65 years old. These are all things according to the CURB 65 score. So CURB 65, okay? So again, someone comes in, they have 0 or 1 of these, give them antibiotics, you can send them home. For patient 1, patient 2. Patient 3 comes in, they're showing 2 signs of these, put them into the hospital for observation and give them this particular antibiotic therapy. Someone comes in, they have 3 or more of these signs, you admit them into the ICU and you follow this category, right? If you suspect that they might have Pseudomonas, you can change up your antibiotic approach. And then we said if they're in the hospital for greater than 2 days or less than 5 days, that's early onset, you'll change up your medication accordingly with this. If they have late onset or they've developed a multi-drug resistant pathogen because they've been there for greater than 5 days, or they have increased susceptibility to Mrsa, right? Then we change up the therapy accordingly, okay? Now, I know we said this, but again, community-acquired pneumonia, minimum of 5 days, afebrile for 48 to 72 hours, and less than 1 symptom of clinical instability. For hospital-acquired, it's generally a minimum of 7 days, but because of Pseudomonas, we usually do it for about 14 days, okay? So about 2 weeks of treatment. And usually, within about the first 2 or 3 days, if they start showing signs of clinical improvement, then we can change up the regimen accordingly, okay? So that's what we'll do for the antibiotic management. But again, remember that these patients are in pain, so you don't always just have to give only antibiotics. You can also give some analgesics to help to lessen the pain. You can also give some antitussives or cough suppressants to be able to prevent that pain from the cough. And these are some of the things that we would do for this patient, okay? All right, guys, so we are almost done. This last thing that we're going to talk about is prevention of complications. It's important. We should be spreading this knowledge of ways that we can help to prevent the incidences of pneumonia occurring. So we do have vaccinations, all right? So what are some of these? So one of the big ones, it's called the pneumococcal vaccine, and it's specifically, they abbreviate it PPSV 23. So this right here is really, really important. So what does the 23 stand for? The 23 stands for the 23 polysaccharide antigens that are present on streptococcal pneumonia bacteria. So let me write that here for you. So it is actually, the 23 means 23 polysaccharide antigens on strep pneumo, so streptococcal pneumonia, right? Now, these antigens that are present on the capsule of these bacteria is really important because these antigens account for 85 to 90% of the invasive strep pneumo species, okay? So that's important as well. So 23 polysaccharide antigens in strep pneumo, 85 to 90% of them, 85 to 90% is for the very invasive strep pneumo. Now, giving PPSV 23, this is really important to give at specific ages, as well as not just specific ages, but if the patient has some underlying comorbidities. For example, this one you'd want to give to patients who are 65 and up, right? That's one thing, annually, so 65 and up. Another situation is you could give this to patients from 2 to 64 years old. But if you're giving it them, you usually give it because they have some underlying disease, like immunocompromised. For example, maybe they have HIV. Maybe they have diabetes mellitus. Maybe they have a malignancy, right? Maybe they have, this butchered malignancy. Or, not just that, but they could even have some type of hemolytic disorder. Sickle cell anemia is another one. Sickle cell anemia, or sickle cell disease, right? These are some situations that you want to be aware of. Another time that you'd want to give this pneumococcal vaccine is if they are 19 years old, they have a history of asthma or smoking. This puts them at a higher risk of developing some type of situation like pneumonia. Now, with PPSV23, you can give it in these situations here, right? There is another one that we can give. And this other one that we can give is called PCV13. And this is the pneumonia conjugate vaccine, right? So PCV13, what does the 13 tell us? It tells us that there's 13 different polysaccharide antigens. So 13 polysaccharide antigens on strep pneumo. Now, you give this vaccine usually less than 2 years old, okay? And you give it at 2 months, 4 months, 6 months, and 12 to 15 months old, okay? Now, when you're giving these, you preferably want to give this PCV13 first. So generally, you want to give first PCV13. Then, after that, about 8 weeks later, so generally about 8 weeks later, this is preferably 8 weeks later, you'll want to give your PPSV23, okay? Now, let's say for whatever reason, you give the PPSV23 first. You have to wait at least a year before you can give the PCV13 vaccine, okay? So again, what I want you to realize is there's 2 main vaccines. PPSV23, this is good for 65 and up. 2 to 64 if you have some underlying disease like HIV, diabetes mellitus, sickle cell disease, or some type of malignancy, unfortunately. 19 years old with a history of smoking or asthma. And then for the PCV13, there's 13 polysaccharide antigens on the strep pneumo. Here's one big difference. All of these antigens are the same as the 23 except one, and that's why it's important. All of them are the same except one. You give this less than 2 years old, preferably at 2, 4, 6, and 12 to 15 months old. Preferably give the PCV13 first, 8 weeks later, give the PPSV23. If this is given first, you want to give the PCV13 1 year later. And again, this is important for prevention. It helps you to develop some type of immunity, okay? Now, last but not least, I know you guys are probably so happy that we finally got here, complications. So here's some things that you should be aware of that can develop with pneumonia if it progresses, if it's not treated properly, if it's just getting worse. What are some of the complications? One of the really, really bad ones is some type of septic shock. This is a really bad one, okay? Septic shock is extremely, extremely dangerous and fatal. Another type of situation that can develop is a pleural effusion, okay? So sometimes what might happen is as the pneumonia progresses and becomes more chronic, pleural effusions can develop and they can also be really, really deadly as well, okay? Next thing is meningitis. Ooh, this is another one. Meningitis is another one that can also develop as well. So you want to remember meningitis. So meningitis is another one. Other things that can develop as complications is abscesses, right? So abscess is. And the really bad one that obviously can come from this is hypoxia. You can develop some really nasty hypoxia, and this can become a problem because of the issues that can develop from this because of the shortness of breath, the improper ventilation, the improper perfusion that can come from pneumonia, okay? So these are the things that you want to be careful of that can develop as a complication from pneumonia, and we have to be careful of this, okay? Septic shock, pleural effusion, meningitis, abscesses, as well as hypoxia. All right, engineers, so we went through it. We finished in this video antibiotic management. We talked about the prevention, like the vaccines that we should be utilizing for pneumonia, as well as some complications, the most common complications that can develop from pneumonia as well. I hope you guys enjoyed this video. I hope it made sense. I really do. I know it was a lot of information, pretty long and grueling stuff, but it is important for us to know these things. So what I want to ask you guys to do is if you guys could please like this video, put some comments down in the comment section. If you guys could go to our Instagram, our Facebook, so we can keep in constant communication with you guys, that would be awesome. Also, if you guys want to go check out our GoFundMe page, donate any amount that you possibly could, we would be grateful for that, or as well as our Patreon, which are in the description box below. Also, We want to thank you guys so much for just watching these videos and being so supportive. We are so thankful to be back and making these videos again. And just Ninja Nerds, can't wait to continue this journey with you guys. All right, Ninja Nerds, until next time.